in the carotid.
Carotid.
Could be, in the heart.
The
with
heart second.
preferential.
Yeah, definitely. It could be hard. But carotid is the first thing comes to mind. If she has something on like ataxia, or she has something different, then you can say heart, right? But embolize, some went to ipsilateral and some went to another circulation. So far we're now, you gave me additional information. There was chemosis, you said proptosis. So what am I thinking? What are you thinking now?
And the first thing we thought of is CC fistula with increased.
No trauma, CC, careful.
Yeah.
What's the difference between CC fistula and dural fistula?
CC fistula is technically a direct communication between the carotid and
Speak a little louder.
A CC fistula is technically a direct communication from the carotid artery to the cavernous sinus, whereas a fistula is more branches from arteries onto the cavernous sinus, like a true dural fistula.
Okay, and we'll take, the direct carotid-cavernous fistula, I agree, it's correct what you say, but so the direct carotid-cavernous fistula, what are the possibilities, the etiologies?
Trauma is the most common.
Trauma used to be the most common.
Yeah.
Depends, now you go to Thailand,
Trauma.
and it's the most common.
Yeah.
But you go to Western countries, and with seat belts, with airbags, the quantity of that has markedly decreased, because most of those traumas to go to Iran, those guys in the bicycle and the motorcycle, a lot of CC fistulas, right? I mean, it depends where. The bullets that are made now, they kill you. You don't have time to survive for getting a CC fistula.
Yeah.
So we have trauma, CC fistula. What are the causes of carotid-cavernous fistula? It's a different disease, so he's right.
So aneurysm rupture, cavernous aneurysm rupture.
A rupture of an aneurysm. Those are the two most frequent causes for this. What is a dural fistula?
A dural of AV fistula
Yeah.
is
And we can even be more precise, a cavernous dural fistula. Although eye findings can come from a dural fistula, the posterior fossa draining to the cavernous sinus. Okay? So, but what is a dural fistula? What's the etiology?
Connection between arterial branches, usually from the
Into a vein. Well, so all fistulas is between artery and vein,
Yeah.
But what's the etiology? Where did it come from?
Usually occlusion, venous occlusion,
Okay, thrombosis. It's a pathological recanalization of thrombosis. Remember, dural fistulas is a peculiar disease. In the dural sinuses, in the folks, even intraos, they most likely are pathological recanalization of a thrombosed vein. So it's a very different disease. So an older woman with the progressive, acute onset, that you think about a dural fistula, not a carotid-cavernous fistula. Unfortunately, it's one of those things that people say one or the other is the same. But you guys are sophisticated, they should know it's a completely different disease. Even if the management may be similar, that means you pack the vein. The approach, the whole thing is very different. The risks are very different. Okay, a carotid-cavernous fistula, an acute carotid-cavernous fistula, is a traumatized artery that is much more fragile. The dural fistula tolerates more because it's a. And then the question is, can we recanalize to reach? But we'll get to that. Now, obviously, this lady, we have something different, right? Here we have this. What is? I mean, you can decide. I don't want to.
Yeah, it looks like there's some edema.
Christina, the first thing when you face, from now to the rest of your life, make an analysis. What are you looking at? Right? This thing here is this thing here, right? Quite interesting. Then let's see the eye. Okay, and we can see that definitely the eye is proptotic, right? Now, when you see that, your eyes have to go to the cavernous sinus and we see a lot of signal voids. I'm waiting. I mean, if you say
and I mean, the next thing was thinking that if it is a fistula there, it could be venous congestion.
Well, you're fixed with the fistula because you know she has a fistula. But when you see this is if this is a fistula, or this is the cause of the fistula, what could it be? How can a dural fistula, let's say in the cavernous sinus, base of the skull, produce this kind of change? I mean,
By venous hypertension?
no, it's venous. Remember, it's a thrombosed vein, so it progresses. So you have arterialized blood going into the venous system, and one of those veins you get like venous infarct. Many times a hemorrhage, and you can see that it has all this mix. Here we have to. The MRI guys will give us. You should tell. Should give us.
So this breakdown of the blood-brain barrier with leakage of gadolinium into the
Right.
basal ganglion region.
Right, so now we can start untightening it. I don't see a prominent cavernous sinus, yet.
There was some flow voids.
Well, I'm looking for that, but I can't. I don't.
I think
quite
more
see that.
front. Yeah, there.
Well, this is sinus, no?
Oh.
I mean, I know she's got a dural fistula, but it's not like a super sticking on my face. Let's see this one. It's moving a little bit. Yeah, maybe there's too many signal voids here. And there is maybe a partially thrombosed superior division of the ophthalmic vein. Right? We don't see a big thrombosed vein. Okay. So, did you put a stethoscope over the eye? Did anybody do? They don't use those stools anymore.
The orbital bruit.
Huh? No more. No, she could have a bruit. She could have. So what happened after? So what did you? So they called you at this stage. I mean, was she transferred? Did she come to the emergency room? How did she come here?
I forget if she was transferred here from an outside hospital, if she came directly, but we planned to do an angiogram. We consulted ophthalmology.
Yeah, the CTA.
We got, yeah,
But what you did suspect a dural fistula because of the eye.
because of the eye.
Okay. So you went to angiography.
Yeah.
So we got 2 angios, right?
Yes.
Yes.
The first one is a complete diagnostic, and the second
11,
one is a treatment.
11 in the morning.
11 in the morning.
Okay, so let's see what we have. Let's change a little bit this thing. Let's do 2 on 1. That's 2 on 1. So we'll do. Okay, so there's the vert. Okay, just when you look at this angiogram, what can you tell me about this individual? Just looking at this appearance.
Hypertension.
Hypertension. It's the first thing that comes to mind when you see, vessels like that, right? She's an older person. Is this atheromatous disease? Probably, okay? It's not spasm, right? Why isn't, look, angiographically, look what I'm doing. I'm going. It stays the same.
Mm-hmm.
Okay? When you have those ripples, sometimes, finding most in the carotid vertex, it will change from frame to frame. Okay?
Even the
yes.
artifact ripples.
Sorry?
The artifact ripples.
Yeah, correct. But here, this is real. You see how what I'm doing is I'm going to see if it changes. It doesn't change. Okay, but definitely this is a typical of hypertensive type appearance. And was she hypertensive? We don't know, but most likely yes. Why did we do 2 runs? Did you do it's more of an oblique? Okay, now this is interesting. Look, okay, so we have to figure out which eye this is. Okay. What is this structure? It's the same as this structure.
Yeah.
Okay? So it's the ophthalmic vein, right? And you see here is the, what, remember we talked, oh no, I haven't given you a talk. When you see in the middle meningeal artery enters the skull, it gives an acute curve. We can do the same with veins. Here, this is cavernous sinus. What is the cavernous sinus in your mind? Is it a big vein? Is it a sinus?
It's a network of
It's a
veins.
network. It's a mesh. It's a network of little veins. And then the drainage of the cavernous sinus anteriorly is
SOV.
the ophthalmic venous system. There is one common ophthalmic vein, and there's a superior division and an inferior division. So anteriorly is the ophthalmic vein. How about inferiorly?
down to the pterygoid venous plexus by foramen ovale.
The pterygopalatine through the foramen ovale, correct. And posteriorly, inferiorly,
IPSS, inferior petrosal sinus.
petrosal sinus, superior and inferior petrosal sinus, and superiorly
Is it parieto-temporal?
actually drains to the cavernous sinus.
Is it parieto-temporal? Sphenoparietal sinus?
Okay, think about the middle cerebral artery, the middle cerebral vein drains in to the cavernous sinus, right? So, you think about it, front, down, this way, up there, and through the bone, okay? So here we just see the superior division of the ophthalmic vein on the right side. The symptoms were on the right side, correct?
Yes.
Yeah, that's very interesting.
Okay,
It's on
this
the
is
left
correct.
side, but kind of drains into
You do look at the neck. Not bad. This is not bad, but there's something interesting here, right? This injection, right? You see anything abnormal? Oh, this is a fabulous picture, actually. Huh.
There's
Inter-
something in the cavernous.
There's something in the
Got
cavernous.
it.
Now, the three of you look at me here. Don't cheat. How is the occipital artery? Don't look now. How is the occipital artery?
It's got changes of FMD.
Look at it again. Look at the occipital artery. Okay? Now I'm going to go back to that vascular, to that vert, and maybe we're dealing with a little variation of it. Okay? This finding, one was reported by a guy called Manelf, is the hallmark of fibromuscular dysplasia. Okay, but you understand why you always look at it. You're not going to miss that because you're looking for something in the cavernous carotid. Come on. But you don't want to miss this because this may be the same as this. Right? It's fascinating, but it is. That's something. We'll look at the other side later on. Okay, but there is something in the cavernous segment. Right? But this, do you think this is symptomatic? This would do anything? If you find a patient, with this kind of a finding here, no symptoms, any risk? Is it subarachnoid? Is it extradural? Where is this aneurysm?
It's in intradural still.
No, it's
It's
extradural.
extradural, so there's no real risk of
The risk is only from rupture causing a CCF or local mass
Can
effect
make
on
a-
the cranial nerves.
But it's rare.
yeah.
There's a guy called Cooper Smith here at Mount Sinai. Another guy called Berenstein reported 100 consecutive cases with cavernous aneurysm, followed for many years. Only one needed to be treated.
Was the treatment because of mass effect?
See what?
Was the treatment because of mass effect?
But yeah, many of those patients would present, let's say, with a third. What cranial nerves can somebody with a cavernous aneurysm present?
Well, most likely 6 because it's closest.
6 is means a more posterior aneurysm.
Yeah.
6
And then 3,
and
4.
yeah, I don't know the incidence, but yeah, 6, 3, and 4. Okay, but even those we treated them conservatively and resolved. Okay, so I think that paper is still valid. Now this is very interesting, right? Because we're seeing this, and I'm looking at everything, right? And what do you see here? Is any abnormality? I can play it. Let me. Yeah, fascinating, right?
Yeah.
You see that this abnormality
Yeah.
here.
There's some small arterial.
There's a network there, right?
Yeah.
Okay, so we can go into what fills this network. What do you think is this blood vessel? This blood vessel, this?
One is the infralateral trunk.
Infralateral trunk. Right? This one is infralateral trunk. Okay, this probably is coming more going towards following the clivus.
Meningohypophyseal.
Well, I don't call it, we call it
The
the
clival
C5
artery.
branches. Definitely here C5 branches. So and here this goes actually the clivus, but this is coming across the midline. So the problem, where do you think is the problem?
Far lateral margin. Yeah.
On the left side. Okay, what's the natural collateral to this territory? In other words, what's going to be your next injection? By the way, here's something else too, eh? We're going to get back to that.
Left
What is the natural collateral circulation of the cavernous segment of internal carotid?
Would be ECA branches.
The external carotid artery. Which one specifically?
So
Back
it
here,
is,
ascend.
ascendopharyngeal.
ascending. Down here,
Is spheno.
internal maxillary. Well, the internal, big one, internal maxillary.
Sure.
Out of the internal maxillary, you have the arterial foramen spinosum, which is which one?
MMA.
The middlemeningeal. Arterial foramen ovale. Which one is that one?
It's arterial foramen ovale.
Accessory meningeal.
Oh.
And arterial foramen rotundum. Okay? And that we'll see what kind of external. But immediately to work this area, the next injection has to be an external. But you have to be an external. Is the problem is that people think that all externals are the same, and they're not. All of us are different. So we have one skinny, one big one, and also we have the proximal external carotid, gives me the ascending pharyngeal. If I put the catheter too high, I do my injection, I may completely miss it. So I have to think, I want to see the territory. Okay, and I actually have something for you guys. And then you see later on that we're seeing the shadow, okay, of a venous, a system, something which we know is going to be, look, here's the superior division of the ophthalmic vein, but we know it's compromised. It has a problem filling and draining. But the next injection should be an external. Who did this case?
I did that.
If you want to see this better, what could you do? Instead of doing 25 obliques.
Rotational angiogram.
Rotation is going to be hard because just make a longer injection. If you make a 4-5 seconds injection instead of a 2-second injection, you're going to feel that better, right? Nothing that, whatever you, let's say, what did they inject here? 8-10 cc's per second? So you do like 8 for 4 seconds, and you're going to feel that a lot better. Now, anything else that we have to be careful of concern? I'm going to give you the 2 previous pictures. We'll come back to that. How is the MCA? The MCA bifurcation?
Looks a
little bit
dysplastic. Yeah.
That would be a good segment, okay? So we know we have a vasculopathic lady. Okay, then you're concentrated into that cavernous. But that middle artery is too big. So the aneurysm here is a little bit of a red herring. Okay, so now we have, okay, so this is the external, and everything is there. Okay, what about this? Let me see if we can, sorry. Okay, the problem of this injection is the reflux into the internal carotid. If you want to, so you want to show this. But can you tell me anything from here, or you need more selective injections? Can you tell me what this is?
Sorry, which one?
Eh? Okay, here is the internal max, right?
Yes.
And then you have one branch. When you can't figure out things, come from distal backwards. Definitely we can see that this vessel follows, there's the grooves, right? And it follows perfectly well the grooves. Look at this middle, it's also irregular, right? Looks like that occipital. Anyways, so this is definitely middle meningeal artery, right? And as I come back to the middle meningeal artery, I find this loop here. This is the foramen spinosum, okay? And I see a network which I knew that was there from the other injection, internal carotid, right?
Mhm.
Okay, and then I keep on going here and I see this network. Do you know what this territory is? It's foramen rotundum. Always goes back like so. So now it's starting to make sense. So this is angiogenesis from the foramen rotundum. But many of these areas is not just one pipe. So we're seeing a lot of little vessels coming from the foramen rotundum, okay, and feeding the malformation. So to see it better, a selective injection would be advantageous. This is the same thing. Okay, let's see what this is. Okay, and here we see that. Okay, so here's. Okay, so to see it better, what you need to do is advance this catheter, put it around here, and then inject a longer. You don't want to reflux to the internal carotid to see it best. But now you see it better. Look, it's peculiar how it goes through the foramen spinosum. Most of the time it's straight like this. So anytime you see this, look also at the orbit. There's no orbital branches. So this is just save image. So what did you do next? Christina? Okay, so you went more distal, okay? Now you see the problem. Okay, you see how much better you see the problem? Now, question is, what is this structure here?
The carotid?
Yes, it's the carotid. How did it feel? Very nice. This is a great case for teaching. Okay. Now, another thing that is useful is always when you do your angios, I don't know if you notice how I put the memory, the positions, my number one position is always the same position. So if I want to know if this compared to this, if I have the same position, it's easier, right? Because here, the reason the carotid looks a little different is because it's a different oblique than the one I picked. Maybe if I take just the lateral, it will look this. Yeah. Okay, so try to do always the injections in the same view. It will make it easier to reconstruct. Okay, now let's put that this is the carotid artery. How did it feel? Christina, I'm picking on you because this is your case. You should know it. How did it feel? We know from before, we know from this injection here, what happened. Where is it? From this external carotid artery, we know what happened, right? What happened here? What's the difference between here and here in the carotid feeding?
Is that in one of them it's there's some retrograde
Called reflux.
Reflux, and then
Yeah,
the other one is
you see it here?
Mhm.
Right? So the catheter is low down here. The pressure of injection was higher than what this system can tolerate. So a little bit of the conscious went down and went up, right? But we don't see that here. A little bit. We know that this can happen. We know that this is the way the inferior lateral trunk refills the cavernous carotid. Okay? And we have to be aware, because if we're going to use liquid embolics, we need to know that this can happen, because I inject the glue now and goes to the brain. Yes? We're together? Okay, so let's continue. Okay. A second pharyngeal would be a good one to have.
Yeah, we didn't, unfortunately. Then we got the, I think, the occipital artery next.
There's a little bit of a second pharyngeal here.
Yeah.
Okay. What do you do next?
I think we went to the next side.
To the opposite side, right? So let's take a look at the bifurcation. Always look at the bifurcation, is a good idea. This occipital doesn't show the problem. By the way, we knew there was a left side, right? We knew that it came across the midline. Okay, so you see how that cavernous aneurysm was a red herring.
Yeah.
So now, okay, good. So now you have the external carotid artery, right? Distal to the pharyngo-occipital and facial, right? And what did you see, Chris? Still different than the other side.
Yeah.
Again, this we don't know exactly what's. We got
Yeah.
a lot of things here.
We see the filling of the cavernous.
Forget it. Forget it.
The
I
network.
don't want to hear that. I want to know what I'm looking at. I know the dural fistula. We already established. We already know all that. Do you know what this artery is here? Any one of you guys can tell me what this artery is here? It's very important because as you'll see why.
Is it accessory meningeal?
No, it's not the middle meningeal.
No, accessory.
No, it's not accessory. What artery is this then? Let's go to what? Again, we go back, right? Look. We go back, it's middle meningeal, right?
It's middle meningeal from.
But here I'm confused what's going on here. Right? It's not easy to. So now I have this other artery here. First of all, you see it's got a concavity like this, and the other one, middle meningeal always has a concavity like that. So when you have this one is the superficial temporal. And in between those two, you will always find the inferolateral trunk. And how do I know? I'm going to tell you how I'm going to differentiate this artery from this artery. I have my one.
No.
Actually, it is a minute. Yeah, okay. See, here you have, a branch of that goes beyond the inner table of the skull. The meningeal arteries will always come to the inner table of the skull. Actually, this means it's reached the midline. So if I look at this picture at the same time, it's reached the midline. Okay? So another way to differentiate meningeal arteries from cutaneous branches is they go beyond the inner table of the skull. This is going to be... Okay? We'll remember this, okay? Between these two, concavity of the middle meningeal and concavity of the superficial temporal, that's where the money is in the anastomosis of the external carotid or middle, with the brain. And now we see this pattern, which is here. This is already the venous drainage, and bingo, man, we can explain everything now. What am I saying? Why am I explaining everything? What
Because
happened to her brain?
we see that there's cortical venous
Yes.
drainage,
Yes,
extensive
This
on the
drainage
right side.
is that she got a venous infarct, probably some hemosiderin and all kinds of stuff, right? But now we can tie them together. Nice case. Now there is something here that I haven't figured out. I have the superior sagittal sinus here. How did it feel? I am a little concerned there may be another fistula. Okay, so I'm here. I see the superior sagittal sinus, right? So now, did it feel from this cortical veins?
So there's also some anastomotic vein on the lateral right.
You mean up? No, but look.
No, on the very lateral, on the right side, on the AP.
Up here?
Yeah, you're kind of
That's
curving.
what I'm saying. I'm seeing this structure that doesn't belong here. And the way it's feeling from distal. It's not draining. I mean, the cavernous sinus doesn't drain to the superior sagittal sinus. So the fact that I'm seeing is the superior sagittal sinus, and I'm looking, is there another fistula? Is there something else? Only selective injection will clarify that. This cortical vein is this one here.
Oh, okay. So that's
Okay.
after the supersatural sinus is filling.
Yeah. But it's not, the question is it draining this way, like that? Or is it draining this way? Oh. Okay, we haven't figured that one yet. But you see what I'm saying? There is more than, we need to be able to, this facial vein is okay. The ophthalmic vein does drain to the facial vein, so that's okay. As a matter of fact, this is a good way to reach it, to cure it. this thing. But why is the supersagittal sinus? So I have been able to clarify that. Where is my angio? You said you have also a treatment.
Yes, that's in the
Okay,
next.
so let me see where you stopped. So we are here. Okay, you did another injection. Let's see what you did here. Still the sinus, but they're not seeing the whole head. Okay. Let's see what we have here. So now is the internal carotid. Okay, they cut the picture too early. We're not seeing the sinus. Okay, so here's another injection. Good, so you took it to the later phase. Huh. Okay, so now you know, you get a diagnosis, you can explain the whole picture. So what are you going to do with treatment? Chest MR emergency procedure at night. Oh, wait, what's emergency procedure at night?
So after we got the diagnostic scan, the initial plan was to proceed with embolization the next day.
Semi-pharyngeal, so you know, that makes sense.
But after we were done, we were called that the patient had experienced some decline in her vision subjectively, and also on the exam of the, like she was now no longer able to count fingers as well. So because of that, we decided to just bring her back and do the case the same day.
Look, there is one thing in dural fistulas, the cavernous sinus, when they deteriorate, that is very helpful. That's to heparinize.
Okay.
Except in this case. Why?
Because of the venous infarct.
Because of what's going on in the brain. You could convert it to a big hemorrhage. So it actually is not unheard of that dural fistulas like this can get worse after an angiogram. It's not unheard of. And there's also spontaneous thrombosis after an angiogram with no treatment. So I'm trying to still don't understand how the supersagittal sinus feels. Okay, the semipharyngeal artery is very prominent here. And there are several branches. Okay, and this is important. We're going to go over a little bit. I have a very nice talk that I'm going to give to fellows for Serenova on functional anatomy. Which next time we meet, I'll give you the lecture to you guys. Okay, then I go to all to this anatomy. But anyways, here is very interesting. I'm still quite puzzled about this sinus. I get the sinus. I have a feeling it's going to be drainage from somehow. Now this is feeling more like draining the lesion. You know what I mean? And even this one is coming this way. See how much better the selective injection tell us? See, I got sinus already there. Unfortunately, here you cut the head. Okay, definitely this sylvian vein feels this way. It's draining the fistula, right?
Yeah.
You might see more of the head under the.
But I'm trying to figure out how this sinus feels.
Dr. Berenstein, where does ascending pharyngeal anastomosis to intracranially? Like, is it the...
The ascending pharyngeal is, how does it get? Well, you have the pharyngeal branch here, okay? And then you have the neuromeningeal branch here. The tangle of vessels are primarily neuromeningeal branch, right? And in addition, there's a thing called the arterial at the foramen lacerum that can connect with internal carotid. Now, in retrospect, I have a feeling what we were seeing there, and that internal maxillary injection, but that was on the right side. This is the inferior petrosal sinus. I'm trying to figure out what the fistula is. This is not the fistula. This is the fistula is here. It's maybe in bone. Maybe the hypoglossal problem is back here. So this is a interesting fistula. It's in the clivus.
Yeah, Greg has said it.
Huh?
Greg has said it before.
I can't hear.
Oh, we discussed
Say
it
it.
before. That it was
It was in the
clivus.
bone.
Yeah, this is not the bone. This is not. This is a little different. Okay. Let's see this one. Okay, so making it bigger doesn't make it. I need to see the drainage here to see what's going on in the. So, okay, here you have also. So now, how are you going to treat it, Christina? What's the risk of the embolization here?
Well, there could be collaterals, as we said, to the carotid, and also to cranial nerves, to hypoglossal.
Cranial nerves. First cranial nerves. What cranial nerves?
Hypoglossal.
What cranial nerves? Hypoglossal is only one.
Glossopharyngeal.
9, 10, 11, 12.
Yes. You need to know. You're not permitted to touch a human if you don't know that. So one of the risks is the 9, 10, 11, 12 cranial nerve. What's another risk? Now the neuroangiography branch of the semipharyngeal artery.
Anastomotic connections to the vertebral.
Then how does it anastomose with the vertebra? You ever heard the odontoid process? Enters at C3. We're not seeing it here, but it will come in like this, around, and enter the vertebral artery. And then here, you can have artery from a lateral entering the internal carotid artery. That teeny little artery is it's a little nutty. Okay, let's see. Okay, so what are you going to do with treatment? So when you went as an emergency, right?
Yes.
Because she got worse. See, John and Tomo, look, I saw in the previous that I'm seeing superior sagittal sinus. I see this drainage to the sylvian vein that way, right? But I wasn't sure how the superior sagittal sinus is feeling. In the previous injection, was more of a bolus injection. That was the day before, the morning before, right? Christina, the one we were seeing?
Yes. The first one we looked at was 10, 11 in the morning, and this was probably around 4 in the afternoon, something like that, when we started.
See, this one was, I wasn't sure how the sinus, why is the superior sagittal? It was one less magnified. So I was a little puzzled. You know, definitely this vein is this vein here. But I wasn't clear here how is the superior sagittal sinus opacified. There was some schmutz up here. And I wasn't sure how, I thought it was feeling more like that. This injection is a little clearer.
Okay.
What did he do here? This is the next day, and this is the.
Is it treatment? That's the treatment.
This is the treatment day.
Mm-hmm.
They both happen same day. The
It was the
treatment
same
is
day.
later.
Yeah, but the night.
The night.
Yeah. I think that the sagittal sinus was filling through.
Is draining the fistula itself.
Yeah, it was like reflux. So the cortical drainage somehow created these anastomotic channels, and then it
Yeah,
went-
she had some venous hypertension, and
Yeah.
yeah, maybe even through here. I don't know.
Yeah.
Yeah. But in that first thing, I said, hey, could it have another fistula? Because the cavernous sinus usually doesn't drain to the supraoccipital sinus.
No,
So
but it's not. It's like draining backwards
Yeah,
to
yeah.
the
But,
cortical
I think
veins.
this becomes.
Yeah, and then out. She's thrombosed every outflow.
Yeah. That's.
The
I
only
mean, you
one.
saw the brain. It was
Yeah.
amazing how the MR of the brain.
Yeah.
Okay, so how are you gonna approach this for treatment? Would you go transarterial? Would you go transvenous? If you go transvenous, how?
We did not want to go transarterial because there's very many tiny branches feeding it from both sides. Wanted to go transvenous to get to the fistula point.
So how are you gonna go transvenous? The veins are thrombosed.
What we wanted to do was go through that facial vein into
Okay.
the superior ophthalmic vein.
How about the inferior petrosal sinus?
We talked about that, but we weren't confident that we could go through there. It didn't show up on the angiograms.
Well,
Looked
that's,
like it was
actually,
occluded.
it's classic. It can't be recanalized. I mean, you don't know until you don't try it. The thing is that the fistula down here, I think it's lower down. It's in the bone and it's, yeah, but look, the facial vein is definitely a possibility. You're gonna have a hard time here,
Yeah.
okay? But it's definitely. But you know, okay. So you tried the facial vein, okay? This is nice. Could be a nice roadmap, right?
Yeah, it's very strange for ascending.
Well, I mean,
veins, yeah.
it's interesting. So, okay, this is the AP. So this is the facial vein of the opposite side.
Yep.
Oh, it's not going to be so easy to go there. Okay. I don't know what this is.
I think that's one of the floral runs.
Oh yeah, that's the microcatheter going up. So we did.
So you call for help.
Yeah. Who's? Tom was there. Yeah. So we did direct EJ puncture.
Yeah. On the right side.
Yeah.
Yeah, we tried first through the.
Yeah, we
Through the
tried.
Yes.
through
Petrosal?
the-
No?
No, actually, we
Or
were about to.
directly facial from the femoral, and it didn't go, so it just.
Yeah,
So
okay.
then we did direct puncture.
We were about to do trans IPSS, but then everything looks so thrombosed. This is going to take too long. Let's just.
I mean, I think that we're learning more and more that this transjugular is actually very, you know, beginning you're not familiar with the procedure, but now we've done it so many times, right? I mean,
Come to here.
yeah.
So this is not IJ, but
EJ,
EJ,
yeah.
Yeah, there's a roadmap that shows. I think before that microcatheter in the neck, it shows that it's weird because usually you can go to the SVC and up, but it didn't connect in
Yeah.
a normal way.
It was like swirling at the end.
Yeah, it was like a reverse curve into the SVC. Yeah, so we couldn't. I think one of those probably shows. Oh, that's the puncture.
nice.
Just the ultrasound guided puncture. Yeah, I think that shows it, but it's not very even. Yeah, the veins there. Yeah, but what Dr. Berenstein, you always get hung up where the angular meets the
Yeah, that's-
SOB. So you could do direct SOB puncture. I called Elmalem.
And she came to expose you there.
No, not that. I said, look, if we can't get it, could we do this? And she said,
With
sure.
yeah, sure.
But we got it soon. It was like evening time. She was home, so.
So wait, I have. Okay, see, here you made it. I'm going backward to 7. This is where a banded guidewire would be fabulous.
Oh yeah. That's,
Yeah, I think we had to switch from to the synchro 10 or just to get through
You
that.
still use the synchro when you got the Aristotle? Isn't that better, the Aristotle?
see, Dr. He doesn't like it.
Why?
It doesn't
It
turn
flips.
1 to 1.
Yeah,
right?
it doesn't turn 1 to 1. The torqueability is
A little bit different.
a little different.
So wait, where are you here?
Is it?
I'm seeing
I
here.
think this is when the ophthalmic stopped filling when we were trying
the
to get
SOV
through.
stuff.
Yeah, this SOV stopped.
It's because you have the microcatheter there.
We had the guiding catheter obstructing the EJ and the microcatheter.
Right.
So that's how you cured it?
Just left it there.
What sheaths did you use and what guiding?
No, benchmark.
Sheath.
6 French?
It was a 5 French in the neck
And an envoy.
And so,
and then
Envoy.
on.
I mean, we had it like.
It
stuck
was
in.
barely like past the short sheath envoy, and then we
Yeah.
used the
We used the
long
envoy
duo.
mainly because we had it open and we didn't want to have our hands near the patient.
Oh, then I want to know how you got there.
So the path, actually, the path.
Did you record it?
Headway
I don't know.
167.
Did we not store the fluoro? Maybe we missed the fluoro on the most exciting part.
This is only one single image.
Where's the- there
So
must
how
be
did you-
ones later on?
You know what might have helped you too? There's the hybrid.
It went not too bad. That's just that's the coiling.
Oh, but then you already called it.
Yeah. It in this view, well, you have the AP of this. What it was, you know, it connects to like the veins going to like the superficial temporal vein, like all of the veins are connecting there. So the path was something like here and then down and then around. Tom actually found it.
Great case. This is a fabulous case. Okay. So, did you do a run once you had the?
There is a transvenous run.
You did a transvenous test.
Yeah.
I want to see if I can figure out the drainage to the superior sagittal here.
Yeah, you see the veins filling, and then it doesn't have the SOV in there, but it anastomosis. I mean, it was. We actually contemplated just coiling off the connection to the cortical veins because it was a single. It's like a single connection.
I probably would have tried to do that first.
Yeah.
If I get them.
But then the catheter, the micro wire, we tried for like 1 minute, and it wasn't. It was like a curve, but the micro wire easily went to the other side. So we said we'll coil that first. If it doesn't
Yeah.
close completely, we.
Why is that important? What Joe just said.
Because there could be small venous connections that if you close the fistula too proximal, then you open up the venous drainage.
And you can't get there anymore. So you first get rid of the danger. The most dangerous part of this lesion is brain hemorrhage, right? The eye, you lose the eye, but you lose your brain. It gets a little more difficult to survive. So you
Yeah.
try to protect the
The
most sensitive area.
This is like the advantage of going trans SOV is that once, if you try to coil the fistula and you don't succeed, you're distal to the fistula, so you can always come back and coil the
Well, after
whatever you
connection
want.
to the
Yeah.
drain.
Oh, you need it for A line? Okay.
They can get an A-line?
They need ultrasound.
What did you use? Just plain coils?
Yeah, we
Smart
used
coil.
the penumbra smart coil.
No fiber coils.
Tom shows those.
What catheter did you use, Joanna? A dual?
Headway Duo, the 167.
Okay, very nice. Nice case.
Yeah, you can't really get a bigger catheter there. I mean, that's the advantage of going through the IPSS is you could put like a 1018 or something and put fiber coils. If you go through transfacial, it's hard to put a bigger catheter.
And you see the other fascinating, this is still not good, but you see all that network that you had, once you close the vein, the network just disappears, which means there's no AVM, there's only V. And those are just collaterals that just suck the blood. Okay, good.
Yep.
Great. Thanks so much. Thank you.
Goodbye, guys.
Thank you very much.